Hello and welcome to a special Childhood Cancer Awareness Month episode of CCLG's Research Talks for Parents and Public. So I'm Ellie Wilkinson and my job is to share our research with our supporters. So starting with some housekeeping, we'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of one using the Q&A button at the bottom of the screen. We may not have time to get to all of the questions because there are a few people joining today. But we will do our best to get there, and I will also give you some information if you have further questions at the end and in the feedback email. If you would like to use the chat function, please make sure you set the to drop down to everyone, or people may not see your message. This webinar is being recorded and will be available publicly on our YouTube channel. We will send out the link when it's ready to watch. So this month's talk is called "What are the long-term side effects of childhood cancer and its treatment?" and is being led by Nicky Webb. So Nicky is a clinical nurse specialist for the long-term follow-up of survivors of childhood cancer in the East Midlands and co-chair of the Aftercure Nurses Group in the UK, and is also part of the European Late Effects Nurses Group. She's passionate about improving care and support for young childhood cancer survivors. So without further ado, I'm going to hand over to Nicky.
Thank you very much. So we've had a bit of an IT issue before we started, so hopefully it will all go nice and smoothly. So thank you very much, Ellie, for inviting me to undertake this webinar. Ellie is going to do all my slides because I can't share them. So I'm hoping if she puts them up. So yeah, so cool, lovely, fabulous. So it's going to be one of those next slide, please, evenings. So like I say, the session hopefully is going to be divided up a little bit for you. And what I'm hopefully going to give you is an overview of what we mean by late effects and late consequences, and how research has influenced ongoing care for our ever-increasing numbers of survivors. I'm going to put a disclaimer before I start. I am not a clinical academic nurse, and I'm not a researcher. So this session might be a little bit basic for some of you out there in the World Web land, but I do things on a very simplistic way. So can we sort of have next slide, please? So it is estimated that in the not too distant future, we're going to have 60,000 survivors of childhood cancer in the UK. And that's probably by about 2026. And 2 out of 3 of our survivors will experience at least one adverse late effect of their cancer or its treatment. And it's also thought there's probably about 50% of our patients that are still lost to follow up. Next slide, please. So what do we mean by a late effect? So I thought I'd give you a bit of a definition. So it's an adverse health-related problem that occurs months to years after completion of treatment. And it's either a result of the treatment or the disease itself. So if you think about the patients that we see, and it's predominantly our neuro-oncology patients, that their tumour hasn't required to have further radiotherapy or chemotherapy, but they've undergone neurosurgery. So they've had an acquired brain injury through a surgical procedure, and that can have quite a profound effect on some children and young people. Next slide. So late effects can be divided into a couple of categories. So we think about the physical things, the physical effects, so the ones that we can see, and that would be either loss of limbs or sight. So we try as much as we can to do limb salving surgery. It disappeared. Oh, I need to move my mouse, Ellie, sorry, because it then disappears off the screen. Oh my goodness. So anyway, and then the next one is obviously endocrine function. So we cannot run our long-term follow-up services without our endocrine consultants and colleagues, and they are our honorary oncologists. So if we have any damage to the pituitary gland, which is your hormone box, which sits between your nose, then we need our endocrine colleagues to support us. And then we have subfertility. So this can mean that we've not affected someone's fertility completely, but we might have given them the chemotherapy can affect their window of opportunity to conceive. So for our female patients, it's the speeding up aging process, and sometimes they can have a reduction in their egg production. So it's more to do with ovarian insufficiency or an early perimenopause and menopause, rather than being unable to conceive. And then obviously there are treatments, sadly, that we use that can affect a young person's fertility. And as part of the CCLG, another group that I'm part of is the sexual health and reproductive group, and actually now being able to sort of be able to protect and preserve fertility far more than we've ever been able to in the past. And then we've got the psychosocial impacts and effects of treatment, and this is massive. If you speak to any of us that work in long-term follow-up and late effects, the psychological impact of going through cancer is really huge. It's linked to body image, which links to our self-esteem. I say to a lot of nurses and medics that don't just think body image affects our teenagers, it can affect our littlies as well. There's a young lady that I support who's in her late 20s, coming up to 30 now, and she was treated as a little person at primary school, and she still thinks people stare at her years down the line. And she, even though she's got a beautiful head of hair now, she still thinks people see her as that bald-headed little person. So our body image and our self-esteem, the steroids that we give young people. Then you've also got education. So where were the child or the young person in relation to their education or the development? So if it was a little baby or a small child, think about your normal child development and your learning milestones. So the critical learning milestones that every single child goes through. Was that little person diagnosed at that time? And we do know that if you don't reach your development milestones when you should, you don't really ever get to the level that we should have, that child would have got to. And we know that for any of us that have worked in child development, outside of nursing or oncology nursing. And then you look at, were they diagnosed at the beginning of secondary school? Has it impacted on their friendship group? Were they diagnosed during their GCSEs? Were they diagnosed during A levels? Were they diagnosed with a brain tumour during their GCSEs and A levels? What were they going to do prior to this diagnosis? And parents of children at diagnosis then start to worry about, will they be able to link onto a job? Will they be able to support themselves? Because usually our education links to higher education, university links to vocational jobs, usually with a higher income. Then that goes into that financial side. So, and a lot of, when I teach junior doctors, I'll say to them, what have you done to get to where you are today? And that's your GCSE points, that's your UCAT, which is the 11 plus for doctors. Then it's what's your A-level scores. And has a cancer diagnosis impacted at those times for our young people? And then throw in neurosurgery and radiotherapy. So there's all those sort of things that we look at. And then frailty. And again, this is something that as nurses working in this field, we're starting to see more of. And that is, again, it's wear and tear on organs. And some of our children and young people, particularly young, sort of coming up into young adults when they were treated as littlies, and if they've had very megatherapy or a bone marrow transplant, they'll often, although they might be 20 or 30, internally they may feel 60 or 70. So it's that frailty side. And we'll come on to that a little bit more later on. So, and sadly, what we are starting to see and become increasingly clear is that cancer and its treatments can have a huge negative effect for our patients that extend beyond that loss of hair or nausea and vomiting, and many are still left with that fear of recurrence, and the trauma that some of our patients experience can be as bad as post-traumatic stress disorder. And what I will say, it is really common, and if any young people are experiencing it, that's the first thing that we say to them. They're not on their own. They really are. It's so common across all our centres when we speak together as nurses. So can we have the next slide, please? So when children come in to have their treatment, they have a combination of chemotherapy. So we use lots and lots of different drugs. And that's basically two reasons. One, we want to maximize cancer death. And all these different drugs work on different parts of the cell cycle. Not going to talk about the cell cycle. I'll spare you that. But basically, each different part of the cell cycle, chemotherapy attacks it, and hopefully kills that cell. So the different drugs that we use hopefully will kill as many cancer cells as we can. Yeah. But what we don't want to use is lots of drugs that just affect the heart or just affect the lungs or just affect the kidneys and the liver, because then you're just going to damage one organ. So we share it out amongst all the organs. And that's the whole idea of combination chemotherapy. So using lots of different drugs that attack the cell at different cycles to kill it, but also reduce the toxicity to those major organs. So that's the terminology, combination chemotherapy. Then we have our radiotherapy. So there's direct and indirect damage. And that is basically what it says on the tin. We want direct damage. So the direct damage is we want to put the beam of radiation into the cancer itself and kill it. Excellent. However, it's got to go in and it's got to come out. So you will get a little bit of damage as it goes in and as it comes out. That's the simple way of doing it. And then think about the edge of the tumour where we're treating, or the edge of the area where the tumour has been removed. You're going to get, with traditional radiotherapy, a little bit of what we call scattering. So the radiation will scatter out a little bit around that. And then think about where that tumour may have been and what is around that area. And also how little the person is. So if they're a very, very little tiny tot, the scatter field might be a lot bigger than if it's an older child or a teenager or a young adult. And that's what we mean about direct and indirect damage. And obviously we have now moved from our photons to our protons. And many of you will have seen the beautiful, pretty pictures of proton beam radiation, where you get a line, it stops dead, it doesn't go any further. And some people I've heard say, calling it safe radiation. It is still radiation. It's still got to go in and it's still got to come out. So at this stage, we are incredibly optimistic, but we're all still very cautious because it's technology and things that we're using in this country. And we will be then, our clinical oncologists will be following these children up in our centres, and we'll be looking and caring for them for a long time, so we get more and more information. So we need the next slide, please. So this is the aim of a long-term follow-up service. So this is where we come in as nurses and as late effects consultants, and we work together in teams to support patients in long-term follow-up. So traditionally, patients are usually 5 years from the end of treatment. That's around about when they no longer need cancer surveillance, and they move across into a long-term follow-up service. Each of our centres may work slightly differently, but that's the main rule of thumb. And the aim of all our services is to, so you've got, again, it's divided up a little bit. So you have surveillance management, which is the medical bit over here. So you've got what sort of scans might we do, what blood tests might we do, what things are we going to be looking at as this young person gets older and goes into their adult life. And the whole idea of that is to minimise the impact on health as they get older. And what I say to nurses and parents who are there, if you think about everything that your child or young person is having prior to their chemotherapy in hospital, those are the sort of things that will carry on in long-term follow-up services. Are we doing heart scans? Are we doing lung function tests? Are we checking kidney function? Are we checking liver function? And those sort of things. So that's the medical side of it. Then we have the education in the middle. So think about a littlie who might have been diagnosed at under 5 or around about 5 or at primary school. A lot of these little ones, by the time they come into the teenage life, have no memory of being on treatment. But their mums and dads have kept diaries, they know everything, and they are the experts. But the whole idea of our services is the attention turns towards the patient themselves, because it's them that's going to be making decisions as they get older, them that are going to be in charge of their own health and needs as they get older. So it's now the time that we actually, the focus is very much more on that child or young person or young adult. So we give them information and we drip feed it in over appointments. So hopefully it gets retained. And then that way they're given the information that they need to make an informed choice as they get older. So it's the health education bit in the middle of it. And it's not really rocket science of what a lot of the things that we tell young children. And then we've got the psychosocial support. And again, I can't emphasize how much this is so a big part of our day-to-day clinical work. And we know, sadly, that we just do not have enough psychology support in any of our centres across the country. And that is sadly a state of fact. And we try and improve that as much as we can. Some centres are better equipped than others. Some centres where there's a lot of neuro that goes on often can have better access to our neuropsychologists. But we also do tap into other community support as well for patients. So I certainly link with the pastoral care teams of primary schools, secondary schools, colleges, universities. We also can access mental health support for young people. Once the young person's 16, it becomes a little bit easier because they can access talking therapies. Under that, it's a little bit harder. But many of our patients don't trigger for CAMHS, and that can be really challenging. But many more secondary schools are getting better at supporting young people in general, not just children that have been diagnosed with cancer. And they'll often have counsellors within schools or safe places within schools. So we can access those side of things. So we have the psychological support. We also have supporting that young person coming through that may have daily challenges, that may have cognitive issues, that may need further support with rehabilitation, and how we link to other services in their local community. Because again, if you think where our CCLG centres are, families might not live on the doorstep, so they might travel to their principal treatment centre. So we need to look at what is available for them in their community and how we link into that and access that. And what we want to do is eventually maximise their integration back into society, because even if they've got challenges, they still feel that they want to contribute to society and feel that they have a place. And also, the one thing that I think became very obvious during COVID was that we weren't doing anything. There was a lot of us that were, a lot of people were at home, and it was great for the first few weeks. It's like being on Jolly Bobs. And then all of a sudden you think, I've got no routine, I've got nothing to do. And it erodes at your sort of mental health and your general well-being. And think about that on a day-to-day basis for some of our patients that have cognitive or physical disabilities. And that is, again, I can't emphasize just how much we do as nurses that work in long-term follow-up services as these patients' key workers, and how we link that through. And then we also look at financial support. As they're coming towards 16, you get the dreaded PIP forms that land, and how we support them in writing PIP letters, putting them in touch with. I am not a citizens advice expert, but my colleagues at Young Lives versus Cancer and for over 18s at Macmillan Work and Money, they are. And we also signpost multiple patients to charities. So we signpost them to the CCLG. So there's groups on there they can access and talk to. There is also the Ellen MacArthur Sailing Charity, where we can access that to support our patients' mental health and help them, put them in touch with other young people. There's a Success charity that's very neuro-oncology related. You have the Brain Tumour charity, the Acquired Brain Tumour charity, and we also have Teens Unite, which is a charity that reached out during the pandemic and did a lot of work online. And then you have other organisations that are just for young people, nothing to do with the cancer world as well. So you have COOTH, and you have other specific childhood mental health charities that are sort of independent to your local area. So there's those sort of services that we can access. And we do have a group of nurses who we talk to one another and we share information as well. So I'll stop waffling on now and move on to the next slide. So who, where, what, and how. So who do we follow up? Where do we follow them up? And who follows them up? I'm not going to go into massive details because we're actually looking at this quite closely at the minute. I've just mentioned at the very beginning, didn't I? 60,000 survivors of childhood cancer. Where are all these children and young people and adults going to be? It's not financially viable for everyone to be in a secondary care follow-up, but we also know there are fewer GPs now than there ever have been. So whether or not, is it fair to have all our survivors only being seen within their GP practice? So that is something as nurses and as the late effect specialist interest group, we're starting to really scrutinise. What information do we give to our patients? How we support them when we do sort of transition them back to primary care. And there are risk stratifications, a way of actually following and looking at patients' needs. So the more treatment that they've had and the more chemotherapy they've had, more complex needs, they might need a sort of more consultant-based follow-up where they're tapping into where they need endocrine support because they're on multiple hormone replacement, or they've had megotherapy or bone marrow transplants. And then we used to have that group of lymphoma patients in there. So those that have been diagnosed with a Hodgkin's lymphoma or a T-cell or a B-cell lymphoma. But actually you'll find those patients coming far more into nurse-led follow-up rather than consultants, because we can probably offer them a little bit longer time in our clinics and we can look at their needs a little bit differently, rather than putting that onto our consultant colleagues who are also doing a lot more of on-treatment work than we are. And then patients that have had low doses of radiation or so predominantly the biggest group that we see in nurse-led clinics are our haematology group. So those that have been diagnosed with leukemia. And then the patients that haven't required radiotherapy or chemotherapy. But again, those patients usually could be our neuro-oncology patients. And although they've not had lots of treatment, they've got complex needs. And actually they may be well supported in a level 3 consultant joined up clinic. So there's a fluidity between the levels, and we tend to follow the same risk stratification. And it was originally done, there's Hamish Wallace, which is one of their Wallace levels. It was put together again by the late effects interest group, and they've also the National Cancer Survivorship Initiative levels. Next slide, please. So linking on to research. And now I was thinking how to approach this, how we link onto research. And I'm really hoping that you've signed in to the other webinars, particularly a certain webinar that was done by the gorgeous Bob Phillips. And I'm actually on the contact editorial committee with Bob. So I meet with him quite regularly now over the Tinternet. But he actually explored, why do we do research in children's cancer? And that's because we want to cure our patients. And so then I thought how to make it a little bit different. So I thought, I know what I'll do. I'll do my timeline as a nurse. And I've been a nurse almost 37 years. And I've been a paediatric oncology nurse for 30 years. So next slide, please. Ta-da! Some of you might recognise that, some of you might not. But that was me. It wasn't me. These are actresses. But that's what I looked like in January of 1987 when I started my nurse training, and I still have my cape. and we did look like power, look like superheroes, and we had paper hats, and it was fabulous. So if I take you back to when I started my training, survival rates for childhood cancer at that time were sort of in the 50s and 60s percent survival rate. And for some cancer groups, that was much lower. And each of our treatment protocols were part of trials, and they still are today. And those are ongoing trials to find out what works and what works best. Now, the treatment back in those days, we didn't know what would work. We didn't know what would cure children. So we used to use really high levels of chemotherapy. And a lot of the time we used radiotherapy as well. And they would also be in high doses. And so it was a little bit like a sledgehammer to crack a nut, as my nana would say. And the brain is an incredibly clever organ. So in the 60s, 70s and early 80s, it was really difficult because the brain didn't let toxins across it, which also meant it didn't let chemotherapy drugs across it. So it had this little barrier, and it's called the blood-brain barrier for those who are sort of non-medical in the audience. And it was really hard to make sure that if there were any cancer cells in the brain or the spine, how do we make sure they were killed off? Well, we used to know they used to get killed off with radiotherapy. So we would use radiotherapy to the head and the spine as standard treatment for leukemia. And there was a time where that would be standard. And then if the child or the young person relapsed and their cancer came back, they would get more radiotherapy to their head and to their spine. And these are the adults that I'm now looking after in my clinics. And there's a lady that I look after, she's in her mid-40s. And she's had the higher dose she was treated for leukemia, but she's had more radiotherapy than we would have given a child who actually was diagnosed with a brain tumour. So it's quite significant doses that we would have given back in those days. Next slide, please. Bye-bye, angels. There you go. Did say at the very beginning, not a researcher. Graphs don't really excite me. They make me sort of go a bit like this. So I thought that was a really simple way of putting it to everybody. So in the 70s, rates were about 40 to 50%. The 80s, they were about 50 to 60. And then you're coming into the 1990s, where it was marvelous. We were seeing survival rates in leukemia coming up into the 70% survival rate. And then we were getting into the 20s, and we were then getting right up into those 80s. And now today, if you listen to Bob, we are really coming up into the high 80s and even into the 90% survival rates for our children. So what we have actually started to see is that we don't need to use the high toxic levels of treatment. We can tweak them. So ongoing clinical trials and research means that we can tweak protocols to reduce that toxicity while still keeping good survival rates. Because what we've actually, going back to the angels, what we've actually learned is from each previous bit of research. So Bob beautifully summed it up. There's no point in doing a bit of research over here and then just doing that over here. You've got to link it all together. So the treatment protocols, we get this one. We then tweak it, we look at what really worked, and then we've got the next one. But for families who don't feel comfortable about going into trials, the previous trial would be then become our gold standard. And that's what we would use to treat the child or the young person. And we learn all the time. So we're now starting to think about cure at what cost. We want to cure our children and our young people because that's what we want to do. We'd actually love to be able to eradicate all cancers. That would be absolutely fantastic. But what we actually want to do is reduce those toxicities and still have good survival rates. Now, again, this is my simplistic way of doing it. So next slide, please. So alongside all our research to do with drugs and radiotherapy and improving our outcomes and everything for our patients, it goes hand in hand with advances in medicine. So we've not just been sort of pootling along. We actually still do use leeches, to be fair. But we're sort of moving on in our methods with how we image children. what is available to us, advances in computers and technology. So improvements go hand in hand in my head. And so diagnostic imaging has changed dramatically over my entire career as a nurse. So we would have had x-rays. We then had CAT scans. Then in the early 90s, MRI scans came in. And you would have medical physics would again improve. Again, don't have a white coat. Don't ask me about physics. Computers, you ought to have been here earlier with Ellie and I. But the computer technology has moved on tremendously. So our clinical oncologists now can program their radiotherapy machines with standard radiation, but the scatter fields are much, much lower than they used to be. So the machinery, the computers has got much, much better. So it all goes hand in hand. So again, we're reducing that scatter field. And then, of course, we've got, and that's a proton machine, didn't know, very pretty. And now we've got our proton machines, which again will reduce that scatter field even more. So each time we're reducing those toxicities with the advances in all this thing surrounding medicine. Talked about it earlier. We're now able to preserve fertility where in the past we've not been able to. So we've been able to, years and years ago, so again, when I started my nurse training, you couldn't freeze eggs unless they were fertilized, because when you defrosted them, they would just explode. Whereas now we can freeze ovarian tissue, we can harvest eggs that aren't fertilized for our young girls. We've got potential of being able to get semen from boys that haven't gone through puberty. So advances are coming through all the time for us. But it's not just the medical advances. We're also looking at awareness programs and how we improve early diagnosis and making it more aware out in sort of the general population. And the one thing that has influenced care in children's oncology, and particularly with our neuro-oncology patients, was the research, the cancer awareness program called Head Smart. Now, if I was really clever, I could have put a little YouTube video in of the Head Smart little dancey, fantastic. Google it on YouTube, put in Head Smart, have a look at it later. It is fantastic. It's a brilliant tool for parents to go to their GP with if they've got a baby, a child, a teenager, a young adult, and say, my child has all these symptoms. Scan their head, please. And it gives them that confidence to approach their GP. It also gives the GP a bit more confidence to say, oh, actually, this is all linking together. Maybe we should be thinking about sending this child for an X-ray or a scan. And it was noticeable when this was launched that we started seeing children a little bit earlier. There was a little bit less delay. There are still delays in diagnosis, and that is another side of our job that we wish we could really keep improving. I remember years ago, we used to say a GP may only ever see one child with cancer in their entire career. God help them if they miss it. But it's that awareness. And we're actually now, charities are going into secondary schools and talking to teenagers and young people in schools and colleges and university. You've got the Ball Basics going in, you've got the Copperfield guys going in, you've got Teenage Cancer Trust going into schools. So really highlighting awareness. So we're getting these diagnoses earlier. And if you can get a tumour earlier, often it can be that little bit smaller. And you've also got machinery now that with a neurosurgeon, they can get their ultrasound machine and go over the brain as they're operating to see minute cells. So it really is everything. Research goes hand in hand, and it all links for us in our long-term follow-up services. So our next slide, please. So late effects research itself. Now, this can be a little bit sort of hard going because the research that we have now available to us that we see in our education days is looking at those patients that I talked about at the beginning that were treated in the 60s, 70s, 80s and early 90s. And that's the papers that we've got and we're seeing. and it's looking at the mortality or the morbidity, which is the chronic illness levels of our patients going forward. But what it helps us do as nurses and professionals that work in long-term follow-up and late effects is it actually gives us evidence to use towards delivery of care. So giving us that, right, okay, this is what's the potential problem over here. What can we do over here to help? How can we support our patients? How can we help them possibly reduce some of these risk factors? How can we make things easier for them? How can we make sure they're getting their benefits that they need? What other things do we need to put in place? And the late effects research that we see most of comes out of our very clever colleagues at Birmingham, and they come regularly to our late effects education days. And I'm one of those that I will sit there, and the beginning of it, it's great. And then they start, and then they put charts up and things, and you just sort of go like this, whoa, because it goes over your head. And then they conclude it. And that's the bit that we really get interested in, because that's the bit that links to our clinical everyday practice. What can we do to help our patients? Then we look at the research papers that looking at effects of radiation, where the scatter field is, how do we support our patients? What do we need to be doing as they're getting older, and how do we help them to make sure? So for example, if it's towards the bowel and they're not absorbing properly, do we need to start looking at getting them seen by someone in gastroenterology? Has the bowel not absorbing properly because there's been some damage from radiotherapy? And then toxicity to other organs. And the main one that we've been looking at as professionals at the moment is to do with cardiac toxicity. And it's not just the CCLG that is part of this. It's actually globally. It's not just the UK. So it's the CCLG together with the Children's Oncology Group, which is the American equivalent. It's groups in Australia, it's in Canada, it's across the whole of Europe. And we're getting information about what's the toxicity in later life when we're giving cardiac toxic drugs. And we're now getting to the point that this influences our guidelines and how we follow patients up. Do we need to scan them every 5 years or every 3 years after cardiac toxic chemotherapy? The evidence for us now through complex research and looking, and it's been scrutinised, and I can tell it's been scrutinised by the specialist interest group who specifically are looking at cardiac stuff, that actually if they've had lower doses, we can comfortably now stop those scans. Nurses, we're a little bit more twitchy and we're sort of a bit like this. And but that's a big thing for a patient, not having to come for a heart scan every 5 years. Reduces that scan anxiety side of things. It helps them get on with their life, which is really important. And then the frailty side of things. And that was, again, it was a day that we spent with our Birmingham colleagues, and they invited somebody that looks after the older population and how frailty and aging cells are in everybody's body. But actually, levels of physical activity kill off aging cells, which I thought was absolutely fascinating. And their research was done on a group of sort of elite cyclists who are now in their 70s. And these cyclists look 70 because they hadn't been through a fountain of youth. So they hadn't obviously gone through water that made them look very young. They still looked 70, but their biochemistry was of somebody a decade younger because their physical activity levels were killing off these aging cells. And it made us think as nurses that actually, you know, the most sedentary group in a hospital, in a children's hospital, is often paediatric oncology patients. And if you're sedentary, you're losing your muscle mass, you're losing your circulatory volume, you're losing, you know, a lot of your energy levels. And actually, should we really be concentrating on improving physical activity levels for our patients? And I don't mean all of them joining a gym or doing proper, you know, exercise. Physical activity can be a multiple of things. And also thinking outside of the box. Majority of centres might be away from where people live, but often a lot of the centres might be close to a park. They might be close to somewhere else where that family can go and visit when they come into clinic. Little things like don't use your wheelchair all the way from the car park to your appointment, maybe just use your wheelchair as you come into the hospital, but then walk around the hospital or walk from your car into the hospital, then use your wheelchair. So just starting to think about how you can improve those physical activity levels and making sure that our patients are sort of actively doing something. And that is the thing that really stands out when we get together with our European nurses, that there is this big emphasis on physical activity and prehabilitation. So rehabilitating patients from diagnosis upwards. And that is something that we've never really invested in. And moving medicine is something that's a big NHS sort of initiative. And it came into adult centres and adult treatments, but it was starting to come into paediatrics, and then the pandemic hit. But find out if your hospital is part of the active hospital group. And if it is, tap into it and see what activities they put on for children and young people while they're on treatment, what they're doing in follow-up, and then what are they doing in long-term follow-up? You know, how are they still getting those activities going? Might improve it a little bit. And then chronic illnesses and looking at patients that were treated historically and what illnesses patients are at risk of and how we support them. And we do know, sadly, that some of our children and young people suffer more than others, but it's something that we are aware of, and we try as much as we can to support them and look at how we can early detect things, which is one of the main things that we do in paediatrics. Next slide, please. So the future. We talked about providing, our goal as nurses is to provide the highest quality of care that we can, linking into much of as we can that's available to us. So we have strong global links. We've talked about that. The world of paediatric oncology is, although we think it's huge, it is huge, but actually it's quite small, and lots of people know each other, and nurses, we know each other, and consultants do, and they talk to one another, and they talk when we have European meetings, we have international meetings where you share all this information. So there's big, strong global links, and there's multiple subgroups within the CCLG. So most of us are members of the CCLG. I'm on, as I've already said, I'm part of the Children's Aftercare group. I'm part of the Contact Magazine editorial committee, which is CCLG. I'm on the specialist interest group, and I'm also on the steering group for late effects as well. And I'm part of the reproductive group. And I've now joined as part of the European nurses group. So we all interlink. And so once a year, it's fabulous that we get together at our annual meeting, because at that stage, that's when us that are no longer really working in that clinical area, we're working more in long-term follow-up, we can sit there, and the meeting is so well put together that we get opportunity to listen to what is going on across the whole of the country, but also what's going on sort of globally as well. And at that stage, it showcases what's research is available and what practice goes across our centres. And this year really highlighted lots of research projects that were going on. And one of them, absolutely, there was 3 of us that work in late effects that were all sitting together, and we were all like, that would be fantastic. And it's actually, we're getting to the point now where you can isolate the genes from each individual child, and you can then work out their own risk in relation to what late effects could be. And the presentation itself was looking again at sort of cardiac toxicities and whether or not certain genetics link to a predisposition to end up with a cardiac, more of a risk of a cardiac late effect. And that is absolutely fascinating, because then you can start to really tailor your treatment to each individual child to reduce that individual child's toxicities moving forward. And all I could think about it, that it was really, really Star Trek-y, and it was absolutely fantastic. I nearly put a picture of bones from Star Trek on that, but the bones that I would have put up would have been Star Trek from the 60s, not Star Trek films and various. So I just thought, I won't do that. I'll do a nice, pretty slide. But the thought of being able to tailor treatment for children again, ultimately, to reduce toxicities, but still providing that high cure rate. And I think as well, when you listen to some of the papers that are coming out and the research and like I say, the advances in medicine itself, you know, really looking at tailoring treatment is absolutely fantastic. And it's very exciting. And for us as long-term follow-up nurses, that helps us then, how do we support our patients in our clinics? How do we tailor our follow-up? Because at the end of the day, that's what we want to do. We want to improve our care for patients. And I could waffle on for ages, but I'm going to draw that now to a close. Say thank you very, very much for listening. I hope it wasn't too basic. I hope it did sort of hit things right for most people. And I think Ellie might say it, but if anybody is worried about anything that we've talked about, you will have a long-term follow-up service within your centre, and we can certainly put you in touch with your centre, or you just speak to your consultant that you're still seeing and ask them about long-term follow-up and who is your long-term follow-up consultant, and which of your long-term follow-up late effects nurses you've got working in your centres. So thank you very much for listening.
Thank you very much, Nicole. It was really interesting to hear, especially what's been going on. I must admit, I had thought that picture was from called Midwife. So, well, I suppose you said it wasn't you, so that's okay. So we're now at the Q&A portion of the evening. So we've already had quite a lot of questions. So bear with us as we try and get through them all. So I think I'm going to start with one that we had whilst you're talking. Is there still follow-up support available for people who are perhaps 15 years post-diagnosis?
Absolutely, yes.
And
yes,
yeah.
yes. So each of your centres should have you'll have a service that goes through to 18, and then we link into adult long-term follow-up services as well. So each centre might have something a little bit different. So what we have in the East Midlands is we have you saw Give a Dinosaur nurse. So I trained as an adult nurse before I trained as a paediatric nurse. So I actually look after, at the moment, everybody. So I've got the children and the adults. And so I'm now looking after adults that I looked after when they were 4. And my eldest patient, she was 10 the year I was born, when she was treated for Hodgkin's lymphoma. So absolutely, you can tap into your late effects or long-term follow-up service, even if you're over the age of 18 and you're 15 years post your end of treatment. Absolutely.
So I'll be sending a follow-up email, a feedback email after this. I will drop some information into it as to where you can find your follow-up care, just in case you've been discharged from it.
Yeah.
So my next question, well, it's actually 2 questions. I'm sort of squidging them into one. Somebody has asked whether leukemia treatment, such as intrathecal methotrexate or other leukemia treatments, can cause or worsen neurodivergence, such as ADHD or autism.
I think that we don't know is my answer to that. I think it gets talked about quite regularly with families and parents. Certainly, some parents have asked if it affects mental health further down the line. We see pockets of it in long-term follow-up, but we don't see masses. So actually, because if you think of the numbers of children that we treat for childhood leukemia, you would suspect there would be more children that we would start to see across the centres. And I think then it would sort of highlight a bit more. But I think my answer to that is I don't really know, to be fair. I think how we have to look at it is that is a way that we do make sure that the cancer cells are killed within their central nervous system. And we have been tweaking methotrexate and intrathecal methotrexate for decades. And whether or not do we need to be bathing the spine in methotrexate. But my answer to that is I don't know if it does or it doesn't. I'm sorry, haven't got a lot of this isn't definitive. I think sometimes how we have to look at something is sometimes you don't know the cause, but you just have to deal what's in front as well. So if you've got a young person with ADHD or a mental health concern or crisis, then you deal with that in that moment and how you support that young person.
Okay, so the next question is, what can we do to support our young people through this to make sure they're not hindered in any way or as much as possible?
Say that again, sorry, Ellie.
Sorry, I went very quiet then. What can we do to support our young people through this to make sure they are not hindered in any way or as much as possible?
I don't quite understand the question. I'm sorry.
Like, what can people do to support young people with cancer to reduce the chance of late effects?
I've reduced the glance. That's so there's a really fabulous edition of the Contact magazine coming out for childhood cancer awareness, and it's got a really big focus on late effects. And that is one of the questions I've actually been asked. So I've got a bit in that, and that there is that whole section on what parents can do and of how to support children through cancer treatment. And one of those things is physical activity, try and keep that going, looking at nutrition and reducing those ultra processed foods, which the companies are incredibly clever at marketing as healthy and directed directly at children. We do know that eating plant diversity, so lots of plants in our diet through a week. So we look at plant points. And a plant can be a coffee bean, a tea, a herb, a spice. So it's adding things into your food and having a diverse amount of sort of plants, and it feeds our microbiome. And that is a big thing at the moment that's coming out for all health. And if we have a healthy gut, it supports our immune system. We've known historically that if you well nourish children on treatment, they fare better on treatment. Doesn't often affect prognosis, but it does help children. In the world of oncology, it's really, really difficult because you've got sore mouths, and they're not just sore mouths, they are horrendous when you've got a child that's got an excoriated mouth, because that is one side of clinical nursing I don't miss, looking after little people with really sore mouths. You've also got taste changes, smells, nausea and vomiting, all kinds of things. And so it's not easy for parents at all, but to try as much as you can to support them with their nutrition and making sure that they're well nourished as much as you can. And it is hard. I haven't got any answers for that, but there is a whole thing in that of keeping children fit and active as much as possible.
Okay, so another question about support is this person's son, he's a teenager, he's not feeling very heard when it comes to medical situations. That's putting them in a very difficult position. How can they help him feel like he is heard, because he feels very isolated at the moment with physical and emotional medical issues?
So when you mean, so is he just, do they feel that that's quite a difficult one? So there's their team around them that's not actually listening to the young person.
I'm not
Is that
entirely
how you've
sure.
sort of interpreted that?
I personally wasn't.
Yes, that's just come up. So they're just not listening to the young person.
Mm.
You can actually very carefully state to the say to the person, that the consultant and the team, that NICE have guidance for teenagers and young adults, that they need to listen to them. You should have a youth service within your centre that you could probably access. Most of our principal treatment centres will have links to Teenage Cancer Trust. So if your young person's been diagnosed over the age of 13, there will be youth workers and support workers that will be there. A lot of centres have teenage and young adult nurses as well that work sort of closely on the wards to help them. It's challenging because that's the heart of paediatrics, is that you listen to our patients and you listen to families, and it's the shared decision making as well. and NICE have got guidance on that for clinicians. You know, we should be making decisions with our patients and our families. And absolutely, that the heart of this is the voice of the young person or child. I would possibly speak. You might even also try and find out who your lead nurse is within your centre. They're often a good advocate for you. Find out who that is, who sort of leads up the oncology service, because they might be able to help. Someone's just flashed up your sort of Young Lives versus Cancer. If they're on treatment, you can certainly tap into the Young Lives versus Cancer service. Gets a bit harder if they're out of treatment because the demands on them are so great. If they've not finished treatment, then you can certainly speak to them. But I would speak to one of the lead nurses and speak to them and say this needs really seriously addressing. Then ask that professional to step in. You can, and then there should be other services as well. So youth workers, teenage cancer workers, and those sort of things. Use them. Quote NICE guidelines at them as well. Teenage and young adult guidance. They need to listen to the young person. Absolutely. From 13, you're entitled to an independent consultation.
Didn't know that.
Yes.
So I know that we're running over a little. Do you need to get off?
Me? No, you're fine.
Okay. Well, we've got loads more questions then for you.
If I can't answer them, what I will do is we can certainly, I can always find people that know a lot more than me. So we can find out for you and we can get back to you, and we can do that through the CCLG.
Yep.
Okay.
So this one is, I think, a little bit of a simpler question. This person's son has had minimal surveillance whilst below 5 years of remission, and they've been told that they're going to be discharged at 5 years. Should they be expecting long-term follow-up?
So if that young person is under the age of 18, then they really need to be seen within a long-term follow-up service, because we like to see children through education. Yeah, is this the lady, the 7, this little person? Did they have treatment? Did they have?
This is a different person, but I do believe.
Okay. Is the question from somebody that's the child's had treatment, or was it a removal of a tumor and they're just watching?
I believe that he had treatment. It's one of our special name funds, so I believe he had treatment.
Okay. If you've had any form of treatment, so you've had chemotherapy, even if it's minimal, you should be followed up 10 years from the end of treatment or up until the age of 18, because you should make sure that that young person has gone through puberty and education. Now, after 18, it depends on your own individual centre. So some of the centres might be able to put you in touch with a long-term follow-up nurse that works within adults. So I'll use one of so for example, our centre. So if we've got a patient who so I've got a couple of my patients that their tumours were removed. These tumours very, very unlikely ever grow back. 5 years end of treatment, they're quite happy to discharge that young person, even though they're still within school and they're still sort of growing and developing, and may also have issues down to their surgery. So those patients moved across into a nurse-led long-term follow-up service, and they are currently under me. Then there are some patients who haven't had any treatment, but have been monitored during childhood. And it might be once they get to 18, they no longer need monitoring, but they just might want to have a question answered in the future. So what we do in that instance is they would have my contact details to say, if they've got any worries or concerns as they go past the age of 18, they can contact me and speak to me. But we get a little bit uncomfortable if you just sort of shoved out the door. So I think I would ask that question of, actually, can they actually go into long-term follow-up, or at least have the contact details of nurses and professionals that work within long-term follow-up in paediatrics and adults. So if they've got a question, they can access it. And that's quite important. So it's knowing where to come back to. So my answer to that would, yes, they should really. I get uncomfortable when people go, oh, it's fine now, 5 years off your trot. No, no.
Okay, so I think one of our other questions is, my daughter had surgery and intensive radiotherapy of the brain and spine, followed by 4 cycles of chemo, and lost her hair during treatment. 3 years on, her hair has not grown back. Is it increasingly unlikely to?
So radiotherapy can, and we do know, can damage the follicles of your hair. And it then is really difficult for the hair to regenerate. So sometimes it is really difficult to see whether or not it's going to grow back. Oh, quick, come back. Right. I wasn't wiggling my mouth. And so I have multiple patients that I see in follow-up that their hair hasn't grown back fully after chemotherapy and after chemotherapy and radiotherapy. And what I tend to do is, if it's chemotherapy related, I will ask my colleagues within dermatology to see patients to see whether or not the follicles are still active. And I can also refer in to dermatology those that have had radiotherapy. And some regions will have a multidisciplinary group of dermatologists that will look at patients' follicles to see whether or not there's any regeneration in there. Sometimes you can get sort of like the follicle, it grows over and then the hair can't come through. And sometimes they can have treatment that release those follicles. Other times they can be destroyed. I'm really very cynical when, I don't like patients just going to go off rogue and try and find hair transplantation, because some of these places can be they just take your money, they're not really interested. And these treatments can be really expensive and they may not work. And then you're just setting that young person up to fail. However, there are plastic surgeons that are linked to the NHS that will offer a free consultation to patients to assess whether or not their hair follicles are going to regenerate or not, and whether or not it is worth then funding a hair transplantation. But it's not uncommon, sadly, to see hair not growing back in radiotherapy fields. But I think it's always worth exploring to see whether or not your local area will be able to tap you into dermatology. And some of them there are multiple treatments that do work that are on prescription. Sometimes these aren't re-prescribable by GPs, but what you can do is look locally to see whether or not you've got a charity that might support you with grants, particularly if you're on a low income. Sort of charity, particularly if you're over 18, you can tap into Macmillan. They do some wellbeing grants, but they are means tested. And then there are some other local grants that can be available to patients. And often Macmillan information centres might have those for the over 18s. But I think it's worth asking your team to refer you to your dermatology team within your centre to see what they think. But yeah, sadly, that's not an easy fix sometimes.
Probably also just worth me highlighting, since we work closely with the Little Princess Trust, that there are free human hair wigs available for children and young people who have lost their hair, which is a very easy process if that's something that your doctor would be interested in. Okay, so next question. This person's son is high-risk acute lymphoblastic leukemia survivor and has been dealing with chronic fatigue for the last 2 years since end of treatment. Is there a chance it will still get better?
Yes, there is. Did you say this person was a little boy?
Yes.
Yes. So it's the treatment currently, it's going to change. And I think it's probably actually started, but the treatment for boys is 3 years. And don't underestimate that final year of maintenance because it absolutely shatters them. And there is a hangover effect from that. And I actually still see it when I see patients 5 years down the line that they're still struggling with symptoms of chronic fatigue, but it does get better. And there are little things that you might be able to do that could improve it. Again, I'll go back to gut health. That is something that we know if your brain and your gut, the two biggest organs in your body, they talk to one another. So if you've got really good gut health and you've got loads and loads of happy bacteria, that supports your immune system in your brain function and your energy levels. So that can sometimes improve things a little bit. I'm obsessed with vitamin D. If there's anybody in the audience that's from Nottingham, they'll just burst out laughing because I am absolutely, it's either hormones or vitamin D at the moment. But vitamin D, I'm obsessed with, and actually hair follicles and skin and our well-being and our energy levels. Vitamin D is a really important little supplement, and we all should be taking it in the winter. But particularly our patients that we've treated for leukemias and lymphomas and brain tumours and solid tumours, they get so many steroids, which can soften bones. So our vitamin D does help our bone structure. But it's also one of those things that feeds into our energy levels. So sometimes if our vitamin D is low, vitamin B12, if that's low, that can make us feel really tired. It might be worth just having a chat with your consultant who you see if you're still sort of within that 2 years end of treatment. Just get them as part of their follow-up bloods if they're doing some bloods on you. Just get your absorption bloods looked at. So your ferritin, your iron stores, your vitamin B12, vitamin D, and sometimes just get them to check the thyroid gland as well to make sure that's working. But they do get better. And sort of look at your physical activity levels and try and get them up a little bit. So get them out as much as you can to help improve them. But it will get better. It just might take a little longer. And certainly I see that hangover very much, particularly in the boys because the treatment is so long. And I see it as well in the teenagers. They get a bit of chemo brain, fatigue, 5 years under treatment, it's still knocking around a bit. It's not quite gone away. But then it will get better for that group of patients. Maybe not so much if we've irradiated your head. That can be a bit of a challenge. But tell him it will get better. Just got to hang in there.
That's really promising to hear. I think quite often you expect to not really hear positive things, so it's quite good for positive. So another question is, will there going forwards be more long-term studies done on survivors that people can get involved with?
Yes. So we're always there's always bits and pieces that are going on in research projects, and that is the other side that our European nurses are in as well. Most of the girls in the group are doing PhDs, but we've got a very active group of clinical academic nurses that work in late effects as well in the UK. We've got consultants as well. They're all linked to the CCLG. So anything that we want sort of survivor input with, that will be on the website. So just keep an eye on the website. I think there's going to be more moving forward as well, because I think we want the voice of the young person in there. We want to know what they would like and what things we need to be looking at as well, and what things we need to be studying. But there are at times multiple bits of research that will come out asking for advice. And at the moment, there was a big thing as well from the CCLG that they were looking for voices of the survivor as well to get in touch. So if you go back and have a look at the CCLG website, there's a link on there that they want to hear from survivors.
I'll have a look and see if I can find that link and we can put it in the email. So This lady would like to know if follow-up care is able to provide or refer to specialists. Sorry, I'll speak up, but this lady would like to know if follow-up care can provide or refer to any specialist dietetics or gastro services.
Yeah.
Yeah.
Yeah. So I refer regularly to multiple professionals and services. So I refer patients to rehabilitation, dermatology, neurology. Dietetics is a little bit different depending on the age of the person. Once you're out of treatment, most of the dietetic stuff in long-term follow-up, we link to community. So we often will ask a GP to help us there because there are community dietitians. So we will then ask those to do it. But no, I refer into pediatric gastroenterology, adult gastroenterology. I refer into endocrinology as well. So if I've got a concern about a patient that's not got any endocrine problems, but I'm a little bit worried about something, very close links to colleagues across our trust. And it's not just that, I refer to cardiology as well and genetics. Just so, yeah, absolutely, we can refer anywhere. The only thing that we get slapped if we do it, and that's if we refer into a service where it's not going to be linked to their cancer. Let's hope there's no commissioners listening in the audience. You can fudge it sometimes. You can sort of you can put little bits in. But if it's really obvious, so if I've got a patient that's got repeated tonsillitis, I can't refer them into ENT because it's not part of their cancer treatment. That has to go from a GP. But I can encourage the GP to do it by saying, this young person's already been through all this. It's impacted on their education. This is all now already impacted on their education. It's a double whammy. Could you please refer them to an ENT for review about X, Y, and Z? So there's things we have a little bit of limitations on, but if it's linked to their treatment or it's linked to their well-being, absolutely, I can refer anywhere. And if your nurse can't in your centre, I'm very surprised if they can't. Most of us can refer into other specialists, but certainly your long-term follow-up consultant would be able to do that.
So I've got a question from a lady in Uganda. Is there any way
where?
Uganda? We've got a very international audience tonight.
Wow.
In the morning for some people of them.
Wow.
So is there any way light effects can be avoided? Their daughter was on Panatinib.
Was on what, sorry?
Panatinib. I'm not sure what it was, but after a molecular relapse, and she's very scared of its side effects. Is there anything that she can do to help avoid the long-term effects?
Don't know. We'd have to look that all up. So that might be one for an email, just so we can have a little look at it and get back to you on that one.
Okay, let me just write that down, and I'll send you an email with further questions.
Yeah, and if I don't know, I can bang it onto somebody clever that will.
Okay. So this person, his son had hepatoblastoma at 7 months old, has hearing loss secondary to treatment and has hearing aids. Are you aware of whether the hearing loss is likely to get worse or to plateau a set time after treatment?
Yeah, it can plateau for some patients. Others, they'll say as they get older, it might deteriorate slightly. So I've got some of my patients who are now in their 30s that had great doses of cisplatin as little people. And they become very adept to their hearing loss as well. So, but we've got some that might need their hearing aids tweaking. Some will go through a phase of refusing to wear their hearing aids. But yeah, it's from what I've seen from the group of patients that I sort of follow up, some will get it'll plateau off, others it might deteriorate, but you should always be under the care of audiology. And that care should transition from from peds into adults. So that should continue. And also I would say as well is make sure that you're seen within the hearing service of audiology, because that links into education, to make sure that things are in place within schools to maximise hearing in school and learning and things like that. So there's a hearing side of audiology that links to education as well. So just when you have a review, check with them on that as well.
So I'm going to say that these are the last two questions because we are losing people, but thank you to everyone who's
Yeah, I was going to say people are going off to get the tea.
Yeah, it's a mammoth session. Thank you very much, Nicky, for all
No,
of the
no
answers.
problem.
So the first of the last questions is it common for children who've had ALL treatment to have learning difficulties following treatment? He finished treatment, their son finished treatment aged 5.
So he was 5 when he finished treatment. So that's another sort of chicken and egg, isn't it? So it's whether or not the treatment's impacted on a learning difficulty, or was that learning difficulty always going to be there? We don't see a massive increase, but it might be that actually because of they've missed little things going on during that time beforehand. So what I make sure is that again, it's that we might not know the reason, but you just need to make sure that the support is there within school. And I know a lot of our sort of outreach nurses and nurses that work within sort of follow up, and the consultants can actually link in and make sure that they're saying to schools they need an education need, they need to be assessed, they need to be looked at. So we can make sure that as they go through primary school, that support is put in place so they can reach their own individual goals, and then make sure that need gets moved to the next level as well when you go up to secondary school and then further on to college. So I think it's more to do with facing what's in front of us rather than having that definitive, was it the treatment that's caused it, or was it the disruption to that little person's very early milestones that's impacted on it. And I don't think you'll ever get a true answer to that. But just make sure that school really put those things in place for your own child so they can reach their own goals.
Okay, so the last question. I feel like I should have saved an inspiring question for last, but
oh no,
so we've had so many. I have to put in the chat, but I will take a note of any that we haven't answered, and I will pass them on to you, and hopefully,
yeah, and like I say, if I can't answer them, I can always find somebody that can.
You have all of the connections.
I do have all the connections. I do, absolutely.
So this last one is this person's daughter was diagnosed at 2 years old, is now 3 years off treatment, and still struggles with a sore stomach every day. They've done an investigation, not really found any answers. They've been told it's a post-treatment side effect. Can they expect it to eventually improve? She had high-risk ALL.
High-risk ALL. So an ongoing tummy pain. That could be so many things, couldn't it? Sadly. I think the reassuring thing on that, if they've been investigated, I'd make sure so if they've done blood samples and poo samples, and I always make sure that they've gone through sort of the gastro side of it. And it's little things that it could just be as well, certain foods that are irritating. So you could keep a food diary if you've not already done that. I'm thinking out loud. And if they've done various different things like that, so it might be certain triggers. It could be that there's lots going on that they're dealing with, and that's how they deal with it because they've got a sore tummy. So there could be multiple things in there, really. I don't know. It's my answer whether it will get better. I really hope for them that they do, because that's just horrendous if they're going to have a tummy ache every day. The reassuring thing is that they've not found anything, which is often not helpful, is it? Because it's nice to have an answer, but there might be other things that you could possibly look at, and maybe explore what's going on in their little world as well. Are they worried about something? Is it something more psychological that's going on as well that's causing that? So without actually knowing you individually, it's a little bit hard to answer. But I think the reassuring thing is if they've not found anything, it's not a common thing that I see in clinic, that you see children that have been treated on the high risk arm of ALL, that they all have ongoing issues with tummy pains. I think Christine's a nasty drug causes constipation and all kinds of horrible side effects, particularly on treatment, bites again later on sometimes. But it just might be that things are just taking a little bit of a settle down, or there could just be things going on in their head that they actually are really struggling with, and that's how they're expressing it. I think that might need more conversation with your consultant and team in your centre. But if there's anything else you want to chat to me about, you could just go through the CCLG, and I can certainly sort of drop you an email.
Yep. My email is going to be on the feedback email, which will be coming after the webinar, but I'm going to take a little time to Google and pack it full of information. So yeah, feel free to drop me an email and I can refer to Nicky or whoever can help. So I think that's all of the questions we can get to tonight. So thank you very much for joining us, and thank you to Nicky for your fantastic talk and many answers. So we have recorded the talk and we will be sending it out in the next few days if you want to share it or watch again. You will also be receiving that email asking for your feedback and hopefully having a lot of information in it. So please do take a couple of minutes to let us know what you thought, and have a lovely evening, everyone. Thank you.